Chris with IBSC. We have Mike and Bryan Boone with Heavy Liza Helmet. We have Salim Rezaie with RebelEM. We have Jordan White with both IBSC and Heavy Liza Helmet on today. And we are extremely thankful and humble to have you guys all kind of jump in and participate with this. You know, the IBSC perspective of the CME Collective has been one of collaboration, trying to find like-minded individuals to help further our industry, further our education, that really kind of drive home the free online access to medical information and education, but also provide industry-leading content that will help grow the CME Collective. And so with that, I want to turn this over to Michael Boone and Bryan Boone with Heavy Liza Helmet and kind of share their kind of perspective on kind of what the CME Collective is and kind of what you guys can expect from future stuff like this.
Yeah, sure. So you said some of this initially, and for those who are just now joining us, they may had missed some of that, but I do want to reinforce how the whole point behind the CME Collective is collaboration. We work in an industry that is multifaceted, involves many disciplines, whether it's someone like Sal, who's working in the ED as a physician versus a pre-hospital provider. We all end up crossing paths, but we definitely have different perspectives. So it's good to have that as a collection. Many people have a very narrow mindset when it comes to their approach. And I think the more people that you can collaborate and the more people that you can get that specialize in those certain areas, it works towards a network that's really going to benefit a large audience. We're going to try to appeal to multiple people from multiple disciplines because we all work in critical care. We all work emergency in some type of facet. So I think it's important that as opposed to competing, that we work together. Like you said, we've surrounded ourselves with like-minded individuals. Us at Heavy Liza Helmet, we've always prioritized quality of character, and that's been something we've definitely found in the collective. But not only that, as far as having that relationship with the providers, we've also got so many tools at our disposal because we've involved so many people that we can really assist each other to provide the best experience for all of our listeners. So not only do we benefit from having those type of resources, but all of you all are going to benefit as well because we're able to have this powerhouse of education to bring you. And we hope to have more opportunities just like this one today. Heavy Liza Helmet, we're huge cheerleaders of IBSC and RebelEM and ECHO. We love all of what these guys are doing. So that's why we're here and we're glad to be here.
Thank you so much, Bryan. Yeah, that's, you know, I couldn't be surrounded with a better group of individuals. You guys have all helped me and IBSC grow, and hopefully we're helping everybody else out. And the big perspective for those of you guys that are just joining on the Facebook Live feed is we want to give back to the community. And this is why all of these fees that you guys will see will always be 100% free. We're providing 1 hour of free continuing education for you guys out there. We're going to do this on a quarterly basis and rotate it through each of the content providers. So IBSC has signed up for the first one, and we'll have one of the other content providers sign up for the second quarter or the next quarter's Facebook Live event. And so we're really excited. Sal, you know, you want to say a couple of words? Jump in here, brother. I know we're all here waiting to hear from you.
No, it's of course. So I think one of the big problems in medicine, and I don't think anyone's going to disagree with this, is we all work in silos. And there's no communication between the silos. And I think this group that we've put together is a representation of what we all find to be the underlying issue in medicine, is that what happens in the pre-hospital environment versus what happens in the emergency department versus what happens in the ICU. Nobody talks. That we all just kind of do our own thing, and then you never learn. You don't know, did I do the right thing? Could I have done something better? And the second thing I would say is that you can always learn something from somebody else who works in a different environment. And sometimes you can take that information and apply it to the environment that you work in. And so I think that's the big thing for me, is that we're creating this sense of community, and it's a bunch of people who are just trying to do better in terms of the way they take care of patients. And I think in the process also help grow everyone else by giving that information out for free so that they can also continue to grow alongside with us.
And that's the nice thing is growing alongside each other, you know, not leaving anybody behind. So that way everybody's kind of learning as they go. And that hopefully promotes the entire industry as a whole, you know, and that way we all learn and grow together. You know, that's the end goal is that, you know, nobody wants to be that guy that got left behind. You know, I know I wasn't to be that guy. And when I was a new paramedic trying to learn and try to get information, it was a struggle to try to find information. Some of the information was different depending on what resource you went with. So, it's been very powerful, I think, seeing the community and the collaboration between everybody and how we can come up with a common message like, hey, I think this is the best foot forward. We should probably go with that, because it's the right thing to do, but it's also because it's evidence-based medicine or, just clinically correct. So thank you, Sal. I sincerely appreciate it.
I feel lucky to be part of the group. Thanks for inviting me.
Oh, absolutely, man. Thank you for coming along on the journey, man. It's all been a fun ride. Hey, Sam, you want to chime in real quick and just kind of let the ECHO people know kind of where you guys are and kind of what the reasons were for kind of this collaboration and this effort?
Yeah, sure. This sort of grew out of our, I guess, feeling that we wanted to be able to extend the conferences that we've been doing out to the world. Like, we could only have a certain number of people at the conference, and we wanted to be able to sort of add that value to the industry. But even beyond that, it's really interesting what Sal said about sort of the silos. ECHO was actually founded on that principle of sort of breaking down those silos, and less within the aeromedical medicine community and more within the public safety aviation community. We're super lucky to have pilots and law enforcement officers and military and search and rescue guys all part of our group. And when you approached us about the collective, and it just seemed to fit our mission very, very closely, of that sort of communicating across industries and sharing knowledge. We all do roughly the same job, and we can share that knowledge sort of across all of our professions, whether it's Sal in the ED, me on a helicopter, the Boone brothers on a helicopter, or the guy in the back of an ambulance, or an ECHO even extends it even further than that and looks at sort of the aviation piece. And we tend to share aviation lessons learned and safety and the peer support and a lot of the other stuff that ECHO does. So it was a perfect fit when we were approached about the collective. And I've always wanted to figure out a way that we could award our members that aren't able to travel all the time for the conferences, be able to award them CEUs and get them the education that happens at the conferences.
Yeah, I think just tagging on that silo kind of comment, it's we do get segregated sometimes, and it's nice. I know working, if you were to look at, one transport agency versus another transport agency, you could almost see in most cases a disparity between common guidelines and protocols and train of thoughts. And I think this is a good collaborative effort to kind of bring some of those like minds and those thoughts together in a more channeled way. The other thing I like to hit on with Sam is if you think about the diversity that we bring, with, Heavy Liza helmet, we got critical care mess, and we also have safety, with Chris Sharp, bringing that in. We have after the call, it's more tailored towards, your middle to line kind of paramedic provider and, nurse to try to develop them even further. We have Salim Rezaie, with RebelEM, and that's able to kind of bring that emergency level, ICU level kind of care. And so when you look at the continuum of thing, going all the way from, just, the line guy all the way through to critical care. So, from the pre-hospital environment to the upstairs, we're able to kind of break that gap, or bridge that gap, I should say, and bring trains of thoughts together. And so that's where the power and collaboration is. So it's not just one thing. It's like you mentioned, Sam, bringing that ECHO, that dispatchers, looking at, aviation, looking at bringing in pilots and getting them involved. So it's a really phenomenal thing to kind of be a part of. So thank you guys. And with that, let's go ahead and get started with our first discussion. So we're looking at the use of epinephrine in out of hospital cardiac arrest. And I know Sal, I know you came out with the Paramedic 2 trial, like you and Swami jumped on that like 5 days after it came out. So you want to take a little bit of a lead here and we'll kind of chime in?
Yeah, I mean, so before we even start talking about Epi, I think like we all get kind of taken aback by new technologies, new medications, new things that we can do. But the one thing when we look at out of hospital cardiac arrest that has been just stood the test of time is high quality CPR and early defibrillation. So before we even start talking about Epi, I think it's important to lay that foundation down, because the things that make differences in our patients' outcomes is that high quality CPR you know, was it witnessed? Was it not witnessed? You know, are we getting that compression rate where it needs to go? Are we allowing full recoil? And then getting those pads on there and see if it's something that's shockable, because there have been plenty of studies that have shown as we start getting later into the cardiac arrest, you know, it may be that we're not doing any service to our patients. And so coming back to the Paramedic 2 trial, this is basically looking at epinephrine and out of hospital cardiac arrest. And it was a huge trial. It's the biggest randomized clinical trial to try and answer this question. Should we be giving epinephrine in out of hospital cardiac arrest? It was like 8,000 patients. It was done in the UK. And they randomized people to receive 1 milligram of epinephrine every 3 to 5 minutes or placebo every 3 to 5 minutes. And what they found is pretty consistent with what the other 8 big trials, which were mostly observational trials, showed, which was improved ROSC, improved survival to hospital, but then we don't see any improvement in survival to discharge and survival with good neurologic outcome. And that's really important, is that who cares if we're getting a bunch of ROSC if all we're doing is creating a bunch of vegetables, right? And so it's a tough question to answer. I think it's a philosophical question. Interested to hear what others have to say about that.
You know, I'll kind of lead off. You know, when I was down in Tucson working for Drexel Heights Fire, we were part of this. We were one of the few first departments that were part of the SARBR study, looking for that constant compressions and out of hospital cardiac arrest. And so I can tell you from my own personal practice, when we had swapped over from the old 30 to 2 to the constant compressions, drop in an OPA, put an on rebreather on, do a drill, get that epi on in 2 minutes, I had a significant increase in ROSC in the field, you know, and then we would bring them into Tucson Medical Center where they'd immediately go right into cooling to go into the UR to basically cool the patient down, neuroprotect them, and then go in and fix the problem, so to speak. And that was, you know, I found a lot of good approaches in that. So it goes back to that, but CPR, I think, that's what was a driving force. You know, we were doing high quality CPR, constant impressions, keeping those coronary perfusion pressures up during the, you know, the entire cardiac arrest. You know, and for me in my practice, I found just a huge spike in that. And then, you know, going on to, hey, now let's start looking at some of the other kind of science behind it. So yeah, I think CPR is definitely a good place to start. We know a lot of people don't do good CPR. That's why we have metrics to now capture that to go, hey, you're not doing good CPR. You're not pushing all the way down. You're not allowing full recoil. And so it's allowing us to objectively learn.
Yeah, it's interesting too, because we can get really even more detailed with this though when we're looking at epinephrine and out of hospital cardiac arrest, because actually I happen to be an ACLS instructor, and the way the algorithm works is that you wait 2 minutes before you give epinephrine. If you defibrillate the patient, you defibrillate, you do a round of CPR, then you reassess, and then you give epinephrine. So but there's also been some information, kind of secondary data on some other studies that also look at the time of epinephrine administration too, may potentially be an impact. And I know, to my knowledge, the Paramedic 2 study really didn't look at timing of administration so much. So I think that's another piece that we need to think about, is if we're going to give epinephrine, that we really need to be prioritizing it. And maybe ACLS has it wrong. Maybe we shouldn't be waiting. If the patient's in cardiac arrest, maybe we should go ahead with that dose. So I don't really know the answer to that, but it seems like it's a question that still needs to be answered.
Yeah, I don't know if that question has really been thoroughly vetted or addressed yet. So it'd be good to see kind of where that's going.
I mean, there's like 3 phases to cardiac arrest, right? There's the initial phase where the patient is like in their electrical phase, where if you can get the perfusion up and not make them ischemic, they tend to shock out of shockable rhythms. And then you kind of get to this like kind of cardiovascular stage where they're just not perfusing, which is what CPR basically saves. And then you get into this like metabolic phase, which is all the derangements and the acidosis. And I don't think epinephrine is really doing any favors or helping in that metabolic phase. But I think in the first 2 phases, which would go along with what we were talking about, is that in the first 20 minutes is probably where you're going to see most of that benefit. You're right. The Paramedic 2 trial did not actually break it down by time. So we don't really know based on that trial.
I think was it the PART trial that looked at, it was one of the secondary outcomes they looked at was the timing of epinephrine administration. So not really one that we had planned on talking about today, but I do think there was some valuable information in that as a secondary outcome that we can gather when we're looking at if we're going to give it epi, how do we prioritize it?
Yeah, and I'd like to ask two questions to you guys as well. A lot of times we hear people talk about epi as dirty epi. So one, what are we referring to when we say dirty epi? And then where do you guys foresee epi being in our clinical practice? Do you guys see a change coming?
Well, when I hear people talk about dirty epi, I think of the dirty epi drip.
Yep,
which,
that's what I think.
Yeah, which became popularized, where people just put a dose of epinephrine in a liter bag and let it run and titrate it to effect, which I really don't understand the concept. I think there's some people in our area that utilize it as kind of an easy way of handling it. I guess I understand if you don't have an infusion pump, but aside from that, to me, it doesn't make any sense.
Right.
Yeah, so I think what we're talking about is the 1 amp of epinephrine, 1 milligram given every 3 to 5 minutes. When I hear dirty epi, I agree. I think of like putting that amp in a liter bag of saline and just hanging that up and letting it run in. And that's why it's dirty, because there's no titration. You're just letting that liter run in.
Right. Okay.
Just gravity fed. Where do
Yeah, and
you
I'll be honest, like anything we name dirty, like that's just kind of degrading our practice, in my
Right.
opinion. Like if we're just gonna we might as well just name it like the cowboy epi drip. Like we're just
or
gonna go
bad
off.
epi?
Yeah, I mean, we're just gonna go off the cuff, and we don't know what the hell we're doing. Like it might work, it might not work, and I get the concept of it. I mean, it's essentially a big bolus pressor dose, which I think there's some good experience and some good data for not giving somebody a milligram of epi and essentially overdriving their heart. I think there needs to be guided resuscitation as opposed to this. I think ACLS is great for the person who doesn't do resuscitation on a regular basis, but anybody who's doing resuscitation on a regular basis, I think it can be fine-tuned and it can be guided a little more effectively. Just my 2 cents on that. I to be honest with you, Jordan, to kind of answer your question about whether I see a change coming, I don't know. Like, it's sort of it goes to the fact of like, what are you going to do? Like, just sit there and look at them? Are we just going to do CPR? Like, maybe that's the answer, but I think if that changes, it's going to be 20 years from now. Like, that's, if anything in medicine changes slowly, it's ACLS, like, particularly. So
to answer that second question, I think you also have to kind of break the environments apart too. So like, the man or woman power that you have in the pre-hospital setting versus the man or woman power I have in an emergency room is going to be completely different. Also, what I have available to me. So not that you guys can't run epi drips, but is that really what the patient needs at that point? Or is that something that we should be talking about, like hemodynamic guided epinephrine drips, like at a later point? I think the more important question that I think will change is how many rounds of epinephrine will you actually give the patient in the pre-hospital setting? I don't think it's realistic from a logistic standpoint or even from a granular like man and woman power standpoint to be running hemodynamic guided epi drips or dirty epi drips in the pre-hospital world. I don't think it makes sense to me. Physiologically, I understand why it makes sense because it's linear and it's titrated to like the individual patient need. But that's just one more thing that you have to do. And I think more and more studies are showing less is more, at least early on. And the CPR and the early defibrillation are probably the things we need to be focusing on. Even airway has been like decreased, right? It used to be a day of like ABCs, and now we're talking about CABs.
Well, just to talk about that, Sal, real quick, have you heard, or have any of you guys on the panel come across, I've heard of people using now Levofed in the intracardiac arrest period, and maybe that might be a better solution, who knows, based on its properties in alpha.
So there are some people that are doing it, but I would say if you're doing it, you're being a cowboy. I don't think the evidence is out there to support it. I think the problem with epi is it's a double-edged sword, and we're getting the results that the drug actually does pharmacologically, which is it's an alpha agonist and it's a beta agonist. So we're basically getting the heart back by vasoconstricting everything. But then the con of that is we're decreasing perfusion to the brain. So we're essentially saving the heart at the expense of the brain. So we're seeing all this ROS, we're seeing more survival to hospital, but we're not seeing anything after that. And so that's why back to the original question was, I do see it changing, but the way I see it changing, at least in the out of hospital setting, is maybe the number of rounds of epinephrine we're giving. Maybe we won't be giving 7, 8, 9, 10 rounds of epinephrine. Maybe we'll limit it at like 3 rounds or something like that. And that's just an arbitrary number.
Yeah, that seems more realistic than maybe the trends of where we're going, and maybe even the timing of when we first apply that first round of epi. You know, building up cardiac perfusion and CCP first with good high quality CPR for maybe 3 minutes, and then consider that first round of epi. You know, that way the heart's nice and primed, but we're not taking so much away from the brain either. We're still addressing the oxygenation status of that as well.
This is a bit of a tangent, but does this feed the mechanical CPR question? Like, I know there's zero data out there that says mechanical CPR is better than a firefighter, but anecdotally, I don't believe it. Like, I really don't. Like, the Lucas device never gets tired, and I can shock through it and the whole thing. So
Sam, when I first started flying, it was nobody wanted to use a ventilator, right? Because it's like, hey, it's a 30, 40-minute transport. I'm just going to bag the guy the entire way because I feel like I'm better. You know, egos get into kind of a play here, I think, a little bit. So once we figured that out, we figured out that we suck at bagging and we could be a lot more consistent, I think, with the ventilator. And so that's where the industry is kind of trended to. It'd be nice to see, hopefully with a little bit more evidence-based studies out there with mechanical CPR to see, you know, hey, is that the best thing that we should be doing right now? I'm with you in that train of thought, you know, especially flying. You know, I suck at CPR in the aircraft. You know, I have to put my back against the bulkhead and kind of do these little half compressions. You know, if I got a Lucas device or an auto pulse, I'll take that, especially it's a post STEMI that we've given TPA to. You know, if you get a teen case, they're going to have a reperfusion. Good chances they're going to code again. So, you know, being able just to hit that and say go while I'm trying to do everything else, it's very helpful. But that's just my perspective.
Yeah, Sam, I think I'm with you.
I'm glad you brought up mechanical. Go ahead. Sorry.
Oh, no, you're good, man. So I was going to say, Sam, I'm with you anecdotally. I haven't seen evidence that says that it's going to increase or improve outcomes. But at the same time, you know, evidence-based practice is essential. But we can also realize and agree, I think, that just because data doesn't exist, a lot of times because it simply hasn't been done or it hasn't been done well, doesn't mean that, oh, it's not useful or it's not going to help. I'd like to see more data on the Lucas device as well, or mechanical CPR devices. Do you know when was the last study, the one that came out 2 years ago? I think it was 16, or has there been one since?
That was the last one.
That was the last one. Okay. Yeah.
So
I think there's just more data needed.
So I'm glad you brought up mechanical CPR. So I love mechanical CPR, and I think, sorry, I don't know if this is PG-13, but I think the data we see is shit. And there's multiple reasons why. So here's the first thing. None of the studies showed that there was worsened patient-oriented outcomes with mechanical CPR. They just didn't show superiority. So that's the first thing to like mention here. So basically, to me, that means equivalent or non-inferior. So I think that means what that leaves is there's some equipoise. And so there are going to be some settings where the outcomes will probably be better. And just from an ergonomic standpoint, make way more sense. And pre-hospital seems to lend itself to that because you just have 1 or 2 man or woman crews. How are you going to sustain high quality CPR for the 15, 20-minute whatever, or a hospital or a helicopter is moving around or an ambulance is like moving around? Is that even safe for the paramedic to be doing CPR? And what's the quality of the CPR that they're getting? And then the 2 other things I would say is if you actually go and look at each of those studies, and I have, there's 5 of them, by the way, last one was in 16. The time to put on the device is an issue that is not discussed in all the trials. And just like any other new technology, if you don't practice with that technology, you're going to make things worse for people. So it's important to practice with these devices and have a smooth, like how to get it on the patient without taking 5 minutes to get the device on and turn it on, because that's time without perfusion, right? The second thing is none of these studies, as far as I'm aware of, showed the location of where they were putting these devices on. For all I know, half of them were up at the aortic arch and not down by the left ventricle. And still, despite that, we still didn't show worsened outcomes for the patients. And then the final thing is I work out in 2 of the ERs I work in. I'm a single doc with 3 nurses, a CT tech, and a janitor. And let me tell you, Carlos, the janitor, is phenomenal at CPR, but he can't sustain that forever. And so I love my mechanical CPR device when I'm out at those facilities. So I think that evidence is shit when people quote it and say, well, there's been no study that's shown benefit. There are a lot of issues with those studies, in my opinion.
Yeah, I would agree, Sally. And I think it just goes back to equipment and training. We know when they first came out with vents, we know a lot of, even to this day, there's a lot of providers out there that aren't very, adept or at that skill set to run a mechanical ventilator. They have the very baseline knowledge of how not to kill somebody, and hopefully not, but they don't have the perspective of why, or, hey, if I need to do this recruitment maneuver, why am I increasing I time, or why am I increasing E time, depending on, your lung disease process. But it goes back to this, I know in the fire department, when we first got our auto pulse, there was a delay. I will be honest to say right now that I was one of those guys that was like, this is a piece of crap equipment, until I learned how to use it better. I practiced with it even more on and off shift. And then when I started actually putting in our pit crew kind of sequence of event, dude, it was phenomenal. But I think it goes back to taking the time out of your day to learn your equipment and learn how to appropriately apply that device and when it would be appropriate to apply that device.
Hey guys, we got a question here. First, what if we could potentially dial in a set milligram dose into a 250 ml bag over 10, 20, or 30 minutes and let it drip in intra CPR? And then also discuss pairing mechanical CPR with ultrasound to verify placement to ensure you aren't mashing on the aortic arch. Those are the two questions that are coming in right now.
So I'll let somebody else field the epi question, but I was part of the rapid response team and the code team at an institution where I worked, and we rolled the Lucas out and did exactly sort of what you're talking about, Chris. Is I was part of the training staff, and I drilled the ever-loving crap out of our people because I did not want them showing up to a code and dicking around for 5 minutes trying to get that thing on. And I would argue that even in hospital, the Lucas made a huge difference just in and this is in an academic medical center where everybody and their brother shows up to a code. Like literally there's like 13,000 people that show up to the code. And if you can put the mechanical CPR device on, it does a couple different things. It calms the room down exponentially. Like immediately, as soon as you put that on and there's not some out of shape guy up there huffing and sweating on the patient, it changes the whole dynamic of the room. And then on top of that, for an academic medical center with an eCPR program, the ability to put mechanical CPR on changes the whole dynamic of trying to get access in the groin, just by the sheer fact of the way the mechanics of the device work. It was actually bought by our perfusion team in the hospital specifically for the eCPR program, but we were able to deploy it for everybody because the CT surgeons saw such a huge difference in getting access to the femoral artery and vein to be able to crash somebody onto ECMO. So from that standpoint, I think it makes a huge difference both in hospital and out of hospital. And we actually had point of care ultrasound that the physician that was responding would throw the ultrasound on right next to the Lucas device. And there were multiple times that we ended up moving it. We would do one round with it sitting way too high, and he would throw an ultrasound probe on while it's running and be like, well, we're just compressing the aortic arch. So we would end up moving it down. And I don't know if I'm sure there's value, but I don't have data behind that. But us moving that, and I think kind of pairing that like you're talking about, there's a lot of value there.
Yeah, so I agree. I mean, in the ER, I do this all the time when patient, and those things slip. That's the other thing. You may start it on the right spot, but then it like slides up, and it's not anybody's fault. It just happens. And so I think to answer your question with ultrasound with mechanical CPR, if you're working with a crew that has the ability to do that, I 100% recommend that, because I can't tell you the number of times I've changed the placement of the mechanical CPR device from the ultrasound that I'm doing. And I'm literally just looking to see that the LV is like going up and down, and it's not just like kind of sitting flat. And then I think the second question was epi in a bag. And so I'm not avoiding the question, but the final answer is that I don't think we really know what the optimal dose of epinephrine is in out of hospital cardiac arrest. I think we know that when you start going higher than a milligram, it's not good. And there are several studies that show, like when we started doing 5 milligrams and 10 milligrams of epi, we were killing people when we were doing that. And the 1 milligram, it looks like, is doing some good things for the heart, but at the expense of the brain. And so the right answer is probably it's going to be somewhere between 0 and 1,000 micrograms. But I think if you're doing quarter dose epi, like 250 mics or 500 mics, I think you're practicing cowboy medicine, because we just don't know. We don't have the evidence for it. And you're just doing something because you have a belief, but there's zero evidence to support that. And I think we will get that answer as research and studies start coming out on that. But I don't think it's going to be a milligram. I don't think that's the optimal dose.
So is there any thought process to blood pressure guided epinephrine and cardiac arrest?
So that's different in my opinion. So again, the evidence is not robust. It's mostly pig models that they've done it in. There are a couple of case reports, but that's about it. We don't have large observational trials. We don't have randomized clinical trials on it. But from a physiologic standpoint, everybody's cause for their cardiac arrest is going to be different, right? And the nice thing about a titrated hemodynamic guided epinephrine drip is that I can put a femoral A line in and I can titrate to a diastolic pressure. And by the way, diastole is when those coronaries are perfusing. And so I'm not giving them that whopping 1,000 microgram. I'm now like using a much smaller dose in a much more linear fashion instead of this like kind of up and down roller coaster of epi the way we do it. And so, yeah, there's some weak evidence from a physiologic standpoint, but from a patient-oriented outcome, we just don't have the evidence yet.
Yeah, I think you just be kind of throwing wind into the wind almost at that point, because we just don't know, until we know where the optimum timing is in the optimum dose. And that obviously we are trending towards that direction with more and more, of the studies that are coming out. And we will probably get there in the next 5 to 10 years, I would imagine, with everything going on. But I think for right now, it's just hard to say, hey, this is definitely the dose that we should be going at, titrate to this effect. But I do think there is something to say about, maintaining that diastolic perfusion, because if we lose that, I mean, obviously you're not perfusing the coronaries. So that's the most important part in this entire, that game, so to speak. So,
but again,
go ahead.
Before we get to that question, I think the important thing is like people get all excited about like hemodynamic guided epi drips and putting in these femoral A lines. But again, you got to start with the basics, and the basics are high quality CPR, early defibrillation. All this stuff we're talking about is after those two things have like gotten started and are being done well. That's when you start thinking about this kind of stuff. And I don't know, you guys work in this environment much more than I do, but what are the ergonomics and logistics of putting a femoral A line in somebody pre-hospital and starting a hemodynamic guided epi drip, and then also getting them to a cath facility or a stroke facility or whatever, like whatever type of facility? What are the ergonomics of that? I don't even think that that's a feasible thing unless you guys tell me different.
It's only feasible if you do it before you leave. Before, like, if I have an A line, if you place the A line and you call for transport, then yeah, I can probably do physiologic guided CPR, and there's value there. Or I preempt. You're in a program that's progressive enough that they preemptively allow you to drop a femoral A line, which I wish, but I think it's pretty rare across the industry. So to your point, it's not. Like, the bottom line is it's not, unless we just happen to be transporting from somewhere where they've already done that process.
Sorry, Justin, I cut you off. You had another question for us. Sorry, I get really excited about this stuff. I don't know if you guys can tell.
So
I think we're all nerding out.
So Justin just sent another question from, I guess, some of the listeners. It said, can you talk a little about the mechanical vents, the plug and play ones that hook up to oxygen and set the respiratory rate and the tidal volume, and that's all? Do you think these are good to be using in CPR? So I'll give my personal opinion on them, because I had to use them when I first started out in transport. I don't think they have a place in the U.S. HEMS or EMS environment, really. And I'll explain why. I think that they can be dangerous, even more so than a BVM. We know with data coming out, BVMs were hyperinflating lungs. We're giving way too much volume. The only thing that these vents, in my opinion, do better is, yes, you can adjust the volume, but we know what happens when we're giving 100% O2. That's never a good thing. And I just don't see why you would go to these vents. A lot of them are still very expensive when I'm thinking about like the save vent or the auto vent or the cat vent. So my personal opinion is I don't think they're great, and I think there's better options out there.
Yeah, I'm going to tag on Jordan right now. Looking back at those BBMs, we knew, and we still do. We still know that through bad ventilations, bad bag mask ventilations, we're going to hyperinflate that interthoracic cavity. You're going to hyperinflate those lungs. You're going to rob preload. You're going to take away from the heart that's already hurt and starving for blood and oxygen. And we see these people because it just goes back to training. It's that adult BVM, 1,200 milliliters. How many people you see deflate that whole volume into somebody's lung? I can't tell you the last patient I flew that was on a mechanical ventilator that had a tidal volume greater than 500. Those pediatric BVMs, those max out at 5 to 800, depending on your BVM device. I'll grab one of those for adult CPR. You know why? Not because I feel like, I need a pediatric BVM, but just to prevent from, hopefully, we all know as epinephrine gets in our system, we start going, we start running just like we're enjoying ourselves now. But when we're in the middle of that moment, it is very easy. And I've constantly walked in on providers doing, CPR and BVM, and they're just squeezing that bag, and sometimes by just going, hey, putting a pediatric BVM, it helps prevent that. Obviously you want to use good chest rise and fall manometers and PEEP valves, and that is the standard of the industry right now. So I think, other devices are out there that are way more conducive. Those auto vents, are rescue vents. I've used them in my practice early on. Yes, it was a save during that CPR event in a resource limited environment. However, I know that it just didn't do good ventilation, and it always went off and alarmed.
I think there's a place for them. Don't get me wrong. I think they came from the military, like most medicine does. It frees up your hands. Certainly there's environments, especially the more austere environments, where they certainly have a place. I just don't see them on these, I've actually seen them on critical care rigs, and they're just not ventilators I feel we should be using in critical care personally. But that's just my 2 cents. We also, you mentioned the pediatric bags. The company I fly for is taking, I believe, the adult bags off, actually.
Yep, I'm aware of that one. And it's just because we're being progressive, and that's the whole idea behind it. We know that this stuff, we can get around it, and it's always outside the box thinking of, hey, can we be doing this a better way? I'm not saying it necessarily is the right way, but is it better than what we're clinically doing now? And we know that people are lending into the worsening outcomes. When you look at some of these studies, I'd like to, like you mentioned, Sal, I wish they would look at each one of those aspects, when we're given epi, when to give it, how much to give it, how much, should we be doing CPR, how much recoil, how much timing, and then looking at the ventilation part, what should we be addressing in ventilations here? Should we just be allowing passive oxygenation? We know that through those studies and passive oxygenation, taking a regular adult nasal cannula, slap it on someone, crank that sucker up to 15 to flush, and next thing you know, you're doing 250 to 300 milliliters of tidal volume without any mechanical respiration. It's just fixed law. It's just gas diffusing. So, is that the best way? I'm not sure. For me, I'm a passive oxygenation kind of guy. Anybody that comes to, listen to me teach, that's what I like to preach. Whether it be a seizure, whether it be CPR, if they need oxygen now, that is the quickest, easiest way that you just can't monkey up, okay, to get oxygen on board somebody. So that's just kind of my thoughts. But good questions coming from the panelists. Anybody want to add?
I mean, I would add that we also have to be careful with how we're bagging people. Like you were saying, our adrenaline's up, we're pumped, and most people, when I see them bagging, they're like bagging like 40 times, a minute. And then, so what do you do when you do that? You blow off CO2, and then when you blow off CO2, what do? You cause vasoconstriction in the brain, and that's also harmful to patients. I think going to the smaller bags makes sense because now you're limiting the amount of tidal volume during that adrenaline provoking event that's like going on. The second thing I would say about bagging a patient is that there are several studies, I think 8, 9, 10 of them now, that show that to appropriately bag somebody, you need 2 people to do it right. You need one person to hold the seal and do a jaw thrust. You need the other person bagging. And again, pre-hospital, again, man, woman power, that's taking up a pair of hands that aren't really feasible. And so I've actually, even in the ED, if they're not intubated pre-hospital, have switched to an LMA. And I drop the LMA down till I get ROSC. And then I'll think about like intubating and all that sort of stuff. But you got to pay attention to these things. So that's my only other thoughts is you got to watch out for over bagging.
I like that you bring that up, Sal, because we're seeing this shift in our industry when we talk about cowboy medicine, where we used to think that you got to get a tube. If you don't get a tube, you failed. And I personally, when I teach, I don't teach that an LMA, a King, a Comp, whatever you're still using is a failed airway. I think it's an alternative airway. And seeing those used more commonly in CPR, I'm really excited about. I think it's good medicine.
Yeah, it makes me happy when I see them come in with like an LMA or a King tube or a Combi tube, because I know they're focusing on what they need to be doing, which is the CPR and not the airway.
Exactly. Yep. I think Chris is muted.
I was gonna say I can't hear Chris. Chris.
I can't hear Chris at all. I see his mouth moving though.
He's testing our lip reading skills.
I like how we were all silent that
I,
entire
I was like, I was checking my connection. Like, did I do something wrong here?
Oh man. All right. I saw him say he would be right back. So moving on. I think we have one more question coming in. Since we're talking about CPR, what are your thoughts about the resuscitation academy some agencies are adapting? I'm going to tap out because I am honestly not sure what the resuscitation academy is.
Agreed. I have no idea.
Yeah, Justin, can you elaborate on the resuscitation academy a bit for us? So, Sal, one of the things real quick that I've seen some agencies going to specifically flight is using epinephrine intra CPR through an IV drip, but it is on a pump. And it is basically giving that 1 milligram over a shorter period or a longer period of time than just a rapid push. I'm not aware of a ton of data on that. So are you aware of the data and is that a good approach?
Yeah. So again, we just don't know. There's not really good data to support that. I think it's all physiologically based. Instead of giving that 1 milligram as like just this push, they're just trying to stretch it out. So they're not getting so much of the beta effects of the epinephrine. But we just don't know. I mean, this is people filling in gaps because we know the 1 milligram push is probably not the best thing.
Right.
But until we have better evidence, you're practicing cowboy medicine. I mean, I'm going to continue calling it that. Like we can all sit here and talk till we're blue in the face about, oh, we should lower our dose. We should be doing this drip. The evidence just isn't there yet. I think what we do know is the current 1 milligram every 3 to 5 minutes improves ROSC, improves survival to hospital, but it's probably even that is probably too much for our patients.
Well, it's funny, like, so they survived to the hospital. Yay. Like that's not, I always hate that as a metric. Like just because they survived to the hospital doesn't mean we did them any favors. Like, and you mentioned it when we first started, like it's a little bit of a philosophical debate. Like just because I can give somebody epi and get their heart back doesn't mean that they are going to go back to where they were before, like, and become a productive member of society. And that's, to me, that's a little bit hard. Like just because we can doesn't mean we should, type of thing. And that's very cliche, but that's sort of how I look at it. And there's been multiple times that I'm sure my flight program was not happy with me that I've gone out to an outlying facility and looked at a patient and been like, why are we going to drag this person across the bay and like into the city where their family doesn't want to go because they never liked the city, and like all of that, and for nothing, so they can get pronounced at another facility. And it's just that philosophical debate of like, what's the end point?
Yeah, I think there's a few ways to look at that. So getting ROSC or survival to hospital, in my opinion, is a surrogate outcome, right? Because the gold standard outcome is survival with good neuro outcomes. But the second way to look at that is, well, in order to have survival with good neuro outcomes, you have to go through each of those things first. Like you have to get ROSC first, you have to get them to survive to the hospital. And so like, you got to hit all those like points before you can get to that. So it's tough. And, you know, one thing I will commend the authors on the Paramedic 2 trial on is they actually polled all the families and patients like after the fact about what their preferences would be. And it was funny that what they cared about most wasn't survival. It was survival with good neurologic outcome, which is what most of our studies should be looking at, and not just ROSC or survival to hospital. But it becomes philosophical, because maybe for somebody, survival to hospital is important for whatever reason, whatever they have going on in their life. And who am I as the practitioner to make that decision for them? It's tough. I think this is like new territory for a lot of us, and there's not a great answer, I think, at this point.
Yeah, I think it's just putting it all together. We're trying to get that complete picture, and we're getting more and more of that complete picture, I think, as we go on. So great discussion about, epinephrine, out of hospital cardiac arrest, and just some of the other kind of tangents we kind of go on. I think they're all very, very important. But now let's shift gears a little bit, guys. Let's move on to the recent vasopressin study that came out for low dose vasopressin and hemorrhagic shock. And just, I think the first thing that I took away from that it was very, very, I was actually happy. First off, anybody who looks at, giving a pressor and hemorrhagic shock, they're like, okay, that's probably the worst thing you want to do. But when you looked at the reduction of the amount of blood products they need to give, because we all, just like, coming back to that cardiac arrest, just because we put a bunch of blood in them does not mean they're going to later survive. Yeah, we might have fixed the initial problem, but we also know that giving multiple units, especially when you start getting above 5 and 6, the complications that come with that, like DIC, and some of the other bloodborne kind of just dissimilar vascular coagulation that occurs, it was very impressive to me to see, hey, we can probably reduce the amount of blood products. So we are getting to the point where, hey, they're survivable. And then going on to that, hey, do we survive after the fact? Did we do such a great job down the ER that, hey, great, now they're going to go home? Or, hey, did we just get them from the ER to the ICU for them to just have a little bit more time with their family members to pass, and that's kind of, what I kind of got out of it. But I'd be very interested to see what your guys' opinions are.
Yeah. So I think, if I understand the study correctly, but really the outcome of mortality was not improved. Mortality of survival, discharge, length of stay, hospital days, all of those other data metrics were really the same between the study group and the control group, the placebo. The biggest difference was reduction in blood products that were administered. So it's an interesting study. I think that, I don't know if everybody else can agree with me, but I've gone through this in my mind. It's like, obviously our bodies are producing endogenous catecholamines during a traumatic experience anyway. So they're in our bodies. So this opinion that giving catecholamines is the devil, to me, it took a little bit to really understand why, because, I get it, but catecholamines are naturally occurring. And, so for us to be administering something like vasopressin and hemorrhagic shock, just to perform that study, I found it really interesting that somebody was looking at that.
Yeah, I mean, go ahead. Sorry, Jordan, you were muted at the beginning. Go ahead.
Oh, sorry, no worries. You mentioned that it was to decrease the fluid, but it was also found to increase the arterial blood pressure and shift the blood away from that subdiaphragmatic bleeding site, which I think is a really important piece when it comes to using the vaso.
Yeah, I mean, there's multiple reasons why this makes sense. The problem with the study, super interesting study, but I think the best you can say about it is it's just a hypothesis generating study at this point. I mean, it was 100 patients at a single center. And I think that the primary outcome of units of blood transfused, it was like 1.5 versus 3 units. So 1.5 in the people who got the low dose vasopressin and 3 in the ones who got placebo, is interesting. Although I've never heard of half a unit of blood. It's usually you get the full unit or you don't. But there was no difference in like the number of the amount of crystalloids that were given, the amount of vasopressors that were needed. And then the most important thing is, did it affect mortality in patients? And the answer is we don't know, because the study wasn't powered well enough. And I think it's a super interesting study. I think it's not a practice changing study. I think that we probably need another bigger study to look at the real answers in terms of patient-oriented outcomes, but super fun to nerd out and talk about it, though, I think from a physiologic standpoint.
One thing I found interesting with the study too, just when you look at the amount of crystalloids infused in these patients, 9.6 versus 10 liters of crystalloids in a trauma patient. So The study definitely has
That's a good
the
discussion.
strange points, as far as is it really applicable to all of our practices? Are we given 10 liters of fluid of crystalloids to our trauma patients? So seems
What's 600
strange.
cc's when you've given 10 liters?
It would, yeah, that was one of the things that jumped out at me was the ridiculous amount of crystalloid that it seemed like they gave these patients. And it was done in Philly, I believe, and my assumption would be that Philly Fire and all of the surrounding areas, none of their pre-hospital providers carry blood. So it'd be really interesting to see that done in a study or in a system that has blood. I know I've heard rumors that Air Methods because Air Methods has this push dose vasopressin in their protocol, which I found out about last year at the ECHO conference when we were doing a sim competition, and an Air Methods employee gave vasopressin as a push dose vasopressor, and the three of us on the panel, all like the judging panel, all looked at each other and were like, do we take points off for that? Like, is that a thing? Because we had never heard of it. Like, genuinely, like it was something I had never heard of doing. So I reached out to some friends in Air Methods, and I think they actually have a study. They're studying this. They're looking at it. So it'll be really interesting to see what comes out of that, because I believe, and Jordan, maybe you can correct me if I'm wrong on this, but I think most of Air Methods is carrying blood. So it'd be really interesting to see what that looks like in a system that can give blood right off the bat and isn't kind of pounding in liters of crystalloid to make the number look better. And that would be my concern. That's always been my concern with vasopressors and trauma is, are we giving it for a good reason, or are we just giving it to make ourselves feel better and make the number on the monitor look better and make us feel better? So, I mean, I don't know. Like you said, I don't know that it's definitely not a practice changing study. I don't think it's even something that's going to really hit the radar for a lot of people. But it does generate a lot of discussion, and hence why we're talking about it.
Yeah, and I think that discussion is, and like you mentioned, it's not a changing study, but it definitely is something to pique your interest in going, hey, is there potentially something there? And there may or may not be. I think this was one of those questions, but I think it leads to a bigger discussion of, going back to what should we be doing for volume expansion in the hemorrhagic trauma patient, that's experiencing shock. Is it liters upon liters of fluid and crystalloids? Is there something else out there? Because we know that all that stuff leads into there. I was nerding out with one of my instructors that was out last week, and we were talking about, why not use, ECMO when they get in, because we know they're in an acidotic state. We know they can't perfuse very well. We know that acidosis leads into that trauma tria to death, but it's just looking at other methods and things out there. So, what would you guys prefer? What do you guys recommend for volume expansion in the trauma patient that isn't going to just wipe them out with hyperchloremia or any of the other lactic acidosis that might be occurring?
In an ideal world, because not every system is going to have this, it's whole blood. Whole blood is the answer. And we're starting to see a lot of trauma trials now coming out showing that whole blood is the way to go. But I also understand the logistics of having those units on the craft or on the crew, and how many of those will be wasted when they don't get used. And there's a lot of things to think about when you say that. But in an ideal world, volume expansion is give them what they're losing, which is whole blood.
You guys are seeing that in San Antonio, aren't you, Sal? Like the
yeah.
decent amount of your EMS guys have whole blood.
Yep.
Which is kind of cool. Most of that is a result of SAMC, right? Like a grant from them. Yeah.
Yeah. So, and we've been seeing some really good outcomes from that. But it's mostly anecdotal and just the system that I happen to work in. It'd be really interesting to see like what their bigger studies kind of show. But I've seen some really good things, but just flooding people with liters and liters of crystalloid, which, by the way, in this study, they got like, let's call it 10 liters, depending on whatever arm they were in. Did you guys see what their overall mortality was? It was still only 12%. Like, that's actually pretty low.
That's pretty low
for getting 10 liters of fluid. Like, I was actually really surprised by that. But again, in an ideal world, I would say you want to give whole blood. That's the answer, I think, unless somebody has like a different thought on that.
I agree. Whole blood's king all day, every day. The problem, as a flight nurse currently working in the profession, I think one of the things we have to accept are the peasants like me on the flight line who don't get to be involved in, finances and how are we going to store and keep whole blood and how do we afford whole blood? What about, let's just talk about EMS right now, rural EMS, they don't have blood. What kind of fluid would you recommend them giving? And, what are we targeting? Are we targeting a MAP? Are we targeting systolic? What would you guys recommend for that?
Yeah, so I think that we have enough evidence that shows flooding people with liters and liters of fluid, crystalloid, is not the right answer. We actually have worsened outcomes. You make coagulation worse, you make their acidosis worse. And so I actually would argue that I wouldn't give more than 500 cc's to a liter. And again, this is not a hard number. It's because every patient's going to be a little bit different, but you want to actually allow for permissive hypotension, which is like one of the main anchors in terms of these trauma patients that are hemorrhaging, because getting them to a normal blood pressure or a normal MAP, they may bleed out even more because they're perfusing wherever they're like bleeding from, and allowing them to be just a little bit hypotensive actually is not a bad thing to limit the amount of crystalloid that they're getting. Because I imagine, again, it's going to depend on the system and how far the nearest facility is, but most people that are working out in rural whatever, what's their transport time, right? And there was a Combat and Pamper, I think, were the two big papers looking at FFP pre-hospital. And what was really interesting, even though it was an aeromedical and ground team study, the aeromedical team had like a 45-minute transport time, whereas the ground team only had a 15-minute transport time. And it was really interesting to see how restrictive they were with their crystalloids in both groups. And so I would argue that, yeah, if you have to give crystalloid, you have to give something, but you probably want to limit the amount that you're giving. Like the days of giving 2, 3, 4 liters of crystalloid should be gone in trauma patients.
Oh yeah, definitely. There was in the Twitter universe, I don't remember, I hate to even bring it up because I don't remember who it was, but I believe it was a trauma surgeon overseas, maybe Australia. He made a point that got shared quite a bit. And I believe it was along the lines of, I would rather have a trauma patient come into my ER, basically not having much brain perfusion and altered with a MAP of 50, then you come in normotensive and now they look like Kool-Aid. And I thought that was a really good point.
I think that was Karim, wasn't it?
Yeah,
yeah.
Karim Brohi is the one who did that.
Yeah.
So what are your all's thoughts with the head injured patient? If you are limited like that, I mean, obviously that's not an ideal scenario.
They're hosed.
Yeah.
Like that's just like, I mean, they're just they're bad off.
Yeah.
Like, they're just rocking a hard place.
Yeah.
I agree.
There's only so much you can do.
Yeah, there's only so much you can do. Like once there's like, brain injury to that patient. And actually, if you like look at, trauma survival, that's like usually one of the first things. If there's brain injury, those people, they end up not doing very well anyway. So they're between a rock and a hard place. But I don't think the right answer is giving them tons of crystalloids still. They were already bad off when you got there. There's nothing that you're going to do that's going to help improve that.
Whole blood.
Yep.
Whole blood. Start thinking about the hypocalcemia as well, because we know out of that UK study, like most of them that came in from a traumatic event that were, hemorrhagic shock, that didn't even get any fluid or blood products beforehand, they already came in hypocalcemic. And we know that, and we know that calcemia leads to, that's the muscle of the cell, or the gasoline of the cell. We need that in order to have cellular contraction and things happen. So, there's other little, I think, components that we might be missing to bring into this and tie it all together as a complete kind of package. So once again, evidence-based medicine kind of leading the way. But real quick, guys, we want to kind of get there towards the wind down and kind of answer any last minute questions we might have out there in the group. So if you're on the Facebook Live and following along, or even if you're on the webinar chat bot, if you wouldn't mind, go ahead and share some questions for the panel. We'll be wrapping this up here in about another 3 to 5 minutes. But all great discussions today, guys.
Yeah, and real quick before we leave, I want to just mention that will be a CME Collective thing going on from now. We wanted to share this with everyone so you could kind of see what you will get being a part of the IMED Collective. The great minds like the Boone brothers, Sal, Sam, Echo, all of us will be coming together to do this on a regular basis. So from now on, it's going to be in the CME Collective group. So if you don't subscribe and you'd like to, and go ahead and subscribe. We'd love to have you.
Yeah, for $49 to get unlimited CEs throughout the year that cover both your state, your national registry, your IBSC or BCEN recertifications. So like you really can't beat it out there. And, and it's what we're trying to do. We're trying to grow the industry. We're trying to grow the collective and get more like-minded people. We do have some more people that will be joining over the next several months. So we're very, very excited at this opportunity just to continue to further our education, learn some more, grow alongside some industry leading people. I'm extremely humbled to be in the presence of all you guys. So I just want to take a minute and say thank you guys so much for being a part of this. And for you, the viewers out there, I want to say thank you very much for joining us today, or if you're catching this at a later date, thank you for following along. We hope to have this more and more of these type of events occur, just to kind of get more interaction between you guys and us. We're just line people doing a job out there, just like you guys. We all want to learn and we all want to do the best that we can. So in that, anybody else want to add some closing remarks, please feel free.
Well, we actually did get a question on the Facebook Live. I just checked. Somebody's asking about intra-arrest targeted temperature management. What are our thoughts about that? So I know there's a data about targeted temperature management, and I definitely think that neurological outcome is good. I'm not real sure about the pre-hospital implementation of it. I think the evidence really isn't there. As far as intra-arrest targeted temperature management, I'm not really sure.
There was a study that came out, it's like 5, 6, 7 years ago, that looked at starting targeted temperature management in the pre-hospital world versus later on in the course, and they showed no benefit. I can't remember the trial right now off the top of my head, but I do remember reading the paper, and it was something somebody studied, randomized clinical trial, and it ended up, that's why you don't see a lot of agencies doing it, because that study showed that there was no benefit. It's just, and it's one more thing to do when you already got enough to do. So if there's no benefit, then why do it?
Right.
When anecdotally, we don't have the resources pre-hospital to manage that temperature and get it exactly. I know when I worked in the ICU, we were using temperature probes rectally. We were using them in the actual central lines, and we were keeping a very finite temperature, and we just can't do that in the field.
No, and there is such thing as making somebody too cold, right? They start shivering and then they start producing heat, and you can't control that in the pre-hospital world. So I think that's why it's a good thought. I think somebody else thought of it, they studied it, and it looks like it doesn't work.
Yeah, it goes back to supporting. There is that finite line. You could go a little bit, but too much, you start living into that shivering, which is going to cause more lactic acid to be released because you're using more cellular energy. So I think at the end of the day, just there's that fine line. But no, thank you guys all for joining in today. I sincerely appreciate that. It's very very appreciative to have you guys on the first ever CME live event. This is a new moment and a new adventure for all of us involved, and we thank you guys all out there for joining along, and thank you guys for being a part of this. We sincerely appreciate it.
Absolutely. Yeah. Thanks everybody, guys. Appreciate it.
Thanks
awesome.
Guys. I can't wait for the next one. This was exciting.
Right? Yeah. This was fun. I enjoyed it.
All right. So 5 p.m. tomorrow, you guys in?
Yeah, I'm ready. Yeah. Let's go. Pick the topics. Let's do it.
Let's keep rolling. Well, thank you, gentlemen, and thank you guys out there for joining. We sincerely appreciate it. You guys have a great day. Stay safe, and as always, check us out and see all the content is 100% free in the CME Collective. If by chance you guys need the continuing education hour, now you can get it. The idea is to put all the collective, the like-minded industry kind of leaders together, making it, because we all know after the end of the call, what are you going to do? You're going to go try to find a resource, and we're using Google. Let's all be real. And we're going to this resource and that resource. What if you could go to one resource and all of a sudden all that stuff is together in one place? And so that's kind of the idea behind the CME Collective. So thank you guys again for joining along, and until next time, stay safe.
Hashtag IAMed for life.
Hashtag the collective. I like it. You guys all have a good evening, guys. Thank you very much for being a part of this.